Welcome everyone. So today we are going to discuss a very important topic, the rabies. Okay. On the first place, why should we even read about rabies? When was the last time you saw and handled a rabies case? It's extremely rare in our locality, right? Then why are we reading about rabies? Is it really rare? So now, why to know about it? More than 3 billion people are at risk of rabies in over 100 countries. And 60,000 fatalities annually worldwide. And among that 60,000, India is accounting for 1/3 of cases. Okay, so this is the disease burden. And moreover, this disease is almost 100% fatal. Okay, so that is the reason you need to know about this, diagnose it at the earliest so that you can save the community, may not be the patient. Now, WHO estimates that over 15 million people receive a post-exposure regimen annually. Okay, this adds to the burden, right? So now, if we think it is only the dogs, we should understand that in various other countries, this zoonosis is caused by various other animals also. Okay, so the vector being the dog in Asia, Latin America and Africa, foxes in Europe, Arctic and North Americas, skunks in Midwest United States and Western Canada, and coyotes in Asia, Africa, North America, mongoose in Asia, Africa and Caribbean, and bats in North America, Latin America and Europe. And this is the region, like no rabies region is at Hawaii, United Kingdom, Australia and Antarctica. Okay, so these are the different vectors. So being an emergency physician, if you have a chance to work in various other countries, then you need to know what type of zoonosis that country suffers from. Okay. Now, let us come to the virus. So rabies virus is a prototype member of the genus Lyssa virus. So how significant is this? These Lyssa viruses are adapted to replicate inside your CNS, inside the mammalian CNS, okay, inside a brain tissue. These viruses can live, replicate and cause infection. Okay. So now coming to how it spreads. Okay. So this picture tells that one zoonotic vector can get infected from the other vector. Okay, so ultimately the salivary gland of that particular animal is responsible for everything because the viral infection resides in the salivary gland of the biting animal. Okay, so this is the reason for the infectivity of that particular animal. So once a dog or the other vector bites a human being, the saliva containing virus is injected into the muscle and the subcutaneous tissue of the humans. Okay, so once the dog bites a human, the virus remains close to the site almost for the entire incubation period. Okay, so now rabies in your nerves. So for the entire incubation period, it is almost at that particular site and then it get attached to your nicotinic acetylcholine receptors in the muscle. That's at the postsynaptic membrane of the NMJ junction. Okay, so after the postsynaptic junction, it jumps to the motor end plate, then ascends and replicates along the peripheral nerve neoplasm. We all know that, right? So this is a nerve. Okay, like this is a presynaptic. Okay, this is a motor end plate and there will be the postsynaptic. Initially, it occurs the postsynaptic area, then jumps to the motor end plate, then again spreads through the other peripheral nerves. It ascends along the peripheral nerves axoplasm. Okay, so after going through the peripheral axoplasm, where does it go to? After this, all these nerves end up into the dorsal root ganglia. So nerves, once the virus gets inside the patient's body, slowly it ascends up from the peripheral nervous system towards the dorsal root ganglia and then to the spinal cord, and the rabies virus enters the patient's CNS. Okay, that's how the patient gets a rabies. Following the CNS replication in the grey matter, once it has reached the central nervous system, again this virus spreads down to all the peripheral nervous system to almost every organ in the body. Okay, so this is how the deadly rabies virus enters into the human being, into the brain. It just replicates inside the brain and just moves towards the other periphery nervous system. Now, in histopathologically, rabies is basically encephalitis. Okay, so once you look at the brain tissue or the brain parenchyma, there will be infiltration of lymphocytes, polymononuclear leukocytes and plasma cells, focal hemorrhages, demyelination in the grey matter of the CNS, basal ganglia, spinal cord, every other part of the CNS is being affected. To be very specific, it is called as a Negri bodies. So this is where the CNS viral replication occurs. So these Negri bodies are eosinophilic intracellular lesions in the cerebral neurons. Okay, these are highly specific for rabies. If you see a Negri body, it is rabies. But this Negri bodies are present in only 75% cases of confirmed rabies. Okay, so 25% cases we were not able to document a Negri bodies. Okay, so I'm trying to tell you that absence of Negri bodies does not exclude the diagnosis of rabies. Okay, if it is present, it's 100% specific. But if it's absent, you need to understand that 25% of even confirmed rabies patients, there was no Negri bodies in the brain. So these are the Negri bodies. Okay, you're able to see that, right? Fine. You need to also understand that most of the cases you see, they will not give you a classical animal bite history. Okay, so in that case, you need to ask them whether they went for trekking inside a cave where there are a lot of bats. Okay, so when you cave inside, when there is a lot of bats, those secretions can fall on you. Okay, you may inspire you, it can come in contact with your eyes, it can come in contact with the mucous membranes, all this stuff. Okay, so bite of a bat usually escapes notice. And human rabies cases with no known animal exposure are most commonly attributed to bats actually. Okay, so don't miss the bat. So now, pre-exposure risk assessment and recommendation. So we know that the rabies is going to be fatal and there is a huge disease burden on the community, and we know how it spreads from one animal to another, from the animal to humans. So after the bite, how the virus spreads into the CNS and how the patient presents, right? So we need to understand, can we do something to prevent? So coming to the pre-exposure, you need to have risk assessment. Okay, so this is the pre-exposure risk assessment. So are you coming under a continuous risk category, frequent risk category, infrequent risk category, or a rare risk category based upon exposure? Okay, are you continuously exposed to the source, or frequently exposed, infrequently exposed, or rarely exposed to the source of the virus? Okay, so continuously exposed means what? Virus present continuously, often in high concentration. Specific exposures likely to go unrecognized, like bite, non-bite, aerosol exposure. Okay, so who are these population? The rabies research lab workers, okay, and the rabies biological production workers. These are called as continuous risk category. What is frequent? Exposure usually episodic. Okay, they go to that particular trekking and they come back, sort of thing. Exposure usually episodic with source recognized. They know that this is where they go. But exposure almost might be unrecognized also. They have gone to the cave, but they don't know whether the bat has bitten them or they have inhaled, or the mucous membrane is exposed to that. Okay, so rabies diagnostic lab workers, cavers, veterinarians, staffs and animal control and wildlife workers in rabies, endemic areas, and all persons who regularly handle the bats or dog and stuff. Okay, so infrequent means the greater population risk. This is very important. Exposure near alwaysly episodic with source recognized. Okay, bite or non-bite exposure, they definitely will know. It's a very infrequent way that once or twice they go for trekking, once or twice they go for caving. It's not a regular habit for them. So these are called as infrequent. Okay, they are veterinarians and animal control and wildlife working with terrestrial animals in areas where the rabies is usually uncommon or rare. Okay, it includes students, travelers to that particular area. Coming to rare, that is population at large, this is where we all come. Exposure always episodic with source recognized. They know that this particular animal has bitten me. They know that this is a very rare cave. They went once in their lifetime and stuff. So this is US population at large, including persons in rabies endemic areas. Okay, so you need to know this particular individual whom you are going to see is coming under a continuous category, frequent category, infrequent category, or rare category. We are speaking about pre-exposure prophylaxis, pre-exposure risk assessment. Okay, so now if your patient belongs to continuous category, what type of pre-exposure recommendations are we going to do? Okay, so you need to complete the primary course, then do serological testing every 6 months, and booster dose if at all. In your serology testing, it comes to be antibiotic on the lower side. Okay, if it's a frequent risk category person, of course give the primary course. The serological testing need to be done every 2 years, not at 6 months, every 2 years, and if at all your antibody titer is less, then you are going to give one booster dose. For infrequent category, of course give primary course. There is no need for serological testing or booster immunization. If it's a rare group, then no need for this primary course also. Okay, so this is the pre-exposure risk assessment, and these are the recommendations. So I was telling you about primary course and booster. What exactly do I mean? What does primary course mean? Primary course means through the intramuscular route, you're going to give either the HDCV or PCECV. Okay, what is HDCV? Human diploid cell vaccine, and PCECV is purified chick embryo cell cultured vaccine. Okay, purified chick embryo cell culture vaccine. So how much? 1.0 ml deltoid area, one dose on 0, 7, 21 or 28. Okay, very important. It is a deltoid area. There are recommendations that you should not give this kind of vaccines in your gluteal region. Okay, deltoid is very, very, very important. And the booster, what I meant is HDCV or PCEVC, 1 ml, one dose on day 0. Day 0 meaning at the time when you're doing your antibody titer checkup and the titer is less than the accepted value, that day itself you need to give a booster. Okay. Now, we know the pre-exposure assessment for risk factors, pre-exposure prophylaxis, everything, yes, done. Now, your candidate is exposed to possible virus source. Okay. So, now what to do? So, once they come with possibly a bite, you need to categorize it as category 1, category 2 and category 3. Category 1 is touching or feeding animals, licks on intact skin. Literally, there is no exposure, right? That is category 1. Category 2, nibbling of uncovered skin, minor abrasions or abrasions without bleeding. So, there is some contact. This is category 2. Category 3 is single or multiple transdermal bites or scratches, contamination of the mucous membrane with saliva from licks or lick on a broken skin or exposure to bats, all these things. So, these are category 1 and category 2 and category 3. This is how you need to classify if at all you receive a patient. Okay, so for category 1 where there is no exposure, no prophylaxis is required. Category 2 where there is only minimal exposure, immediate vaccination is recommended. For category 3, immediate vaccination and administration of rabies immunoglobulins are also recommended. Okay. So, post-exposure prophylaxis. When you are speaking about post-exposure prophylaxis, we classify it as category 1, 2, 3, right? It doesn't only depends upon the bite or exposure. It depends upon various other parameters also. Okay. It depends upon a bite, or is it a scratch, or is it a non-bite exposure, number of bites, the depth of bite, the location of the wound. Is it very close to the central nervous system like head, or it is very distal to the central nervous system like the foot. Okay. So, those things also matters. Not only this, the epidemiology of animal rabies in that particular area, how common is that? And knowing the species of animal involved, we saw a lot of species. Is it a bat induced or is it a dog induced? All these things we need to know. Clarifying the circumstances of exposure incident, whether the animal bite only this candidate or is biting many people, all these things. Okay. Determining if the animal can be safely captured and tested for rabies, or it's an unknown animal ran away, it cannot be captured, all these things you need to know. Okay. So, in our days when we were doing our schooling, we read something called as a provoked and non-provoked attack. But now this distinction between the provoked attack and a non-provoked attack should not be used. Okay. So, what is the meaning of provoked attack and non-provoked attack? It was said that provoked means this particular candidate goes to the dog, maybe he stamped over the tail or took its food or something like that. That's called as induced or provoked. Non-provoked means the candidate was just standing and this rabies dog was biting everyone. Okay, this is a non-provoked. So, this kind of provoked and non-provoked category is no more in use. Because from the situation point of view, if the animal feels endangered, if the animal feels there is threat to its living or its food, it's going to attack, right? Unless they are so much confused. So, this particular terminology like provoked and non-provoked is usually not used nowadays. Okay. Understand? 15% of animals with rabies do not exhibit aggressive behavior because they are dumb rabies. They are apathetic. Okay, they are dumb rabies. So, understand that rabies animals need not be always in a very ferocious state. They can be dumb, dull and quiet state also. Okay. So, now you have received a patient. You start here. You have received a patient with a possible exposure. So, you are asking all these information which we saw in the previous slides. The animal, what species it is it capturable, all these things. So, animal species, salivary exposure to wound or mucous membrane, or and the animal available for observation, all these things you are going to check. Okay. So, if it's a carnivore, okay, if it's a carnivore or the livestock carnivore or bat with salivary exposure, So this thing you are going to check. So now comes to your categorizing as the dog, cat or ferret or other carnivore. In case of dog, cat or ferret, what we are going to do is we are going to give you an option to wait for 10 days. Okay. In the other carnivores, no such option to wait. Okay. This is what the overall classification is. For dog, cat and ferret, check whether the animal has escaped. If the animal has escaped, then you need to think, are you in a region where there is rabies is more common? Okay. If it's not so common, then prophylaxis is not required. If it's more common, then you need to proceed with vaccine and immunoglobulins. That's what's written here. Epidemiological absence of rabies risk in species and in geological area. You remember we had our second slide where I showed multiple animals and I showed which zoonotic vector is reason for this zoonosis, right? We showed one area where the rabies is very uncommon, like UK, Antarctica and stuff. So you need to check whether in that particular area, epidemiological area, is rabies common or it's absent. Okay, if it's absent, then prophylaxis is not required. But if at all epidemiological rabies exist in that particular area, then you have to give vaccine plus HRIG, immunoglobulins. So now it is not escaped, you have captured and quarantined, then you have the option to wait and observe for 10 days. Okay, in 10 days the animal has a normal behavior, animal release, prophylaxis is not needed. Okay, and this is for the dog, cat or ferret. If at all you find any strange behavior, sacrifice the animal, then you are going to refrigerate, examine the brain for Negri bodies, and then you are going to proceed further. If you have confirmed that it is a rabies animal, then complete the course of vaccine plus HRIG. If it's not rabid or the vector is not affected with rabies, then you can discontinue the vaccine. And prophylaxis also is not needed because it's not an infective source. Okay, so we are not trying to treat a dog bite. Okay, we are trying to treat the rabies virus in the dog bite. So if the dog has been confirmed that there is no rabies in it, then no need to treat for that particular virus. Okay, so this is for dog, cat and ferret. The same thing is true for other carnivore as well. But the point is, only for dog, cat and ferret we have this 10 days window. For other carnivores, every other carnivore who has bitten is taken to be rabies affected. Okay, so animal escape, vaccine plus HRIG. If it's captured and quarantined, then you have to sacrifice and the animal refrigerate and send to qualified lab, examine the brain for Negri bodies. If Negri body is present and is going to be turned to be rabid, then you can complete the course of vaccine by HRIG. If the animal is not rabid, is negative, then discontinue the vaccine and prophylaxis not required. Okay, so to be more clear, rabies post-exposure risk assessment and recommendations. Dog, cats and ferrets, if they are healthy for 10 days, okay, the person should not begin vaccination unless animals show some signs. Okay, rapid or suspected, rapid, unknown, then immediate immunization is required. For other carnivores, always consider this to be a rapid unless the animal is proven negative by the viral serology. Otherwise, consider immunization. Otherwise, livestock like horses, rodents, rabbits, you need to consider individually whether this particular animal is being observed or is this particular animal showing any various other signs of rabies, all these things. Always consult with the public health officials and they will decide whether how to proceed with this kind of animal bites. Okay. Now coming to the bite per se. Okay. So which animal has bitten? So bites from healthy appearing animals. The CDC, the Center for Disease Control and Prevention, recommends that healthy dog, cat or ferret that bites a person to be confined and observed for 10 days. Okay. And the first sign of illness should be evaluated by a veterinarian and report immediately made to the local health authority. Okay. If the veterinarian gives you a suggestion that there is signs of rabies, the animal has to be euthanized, head removed, shipped under refrigerator, it should not be frozen. Okay. For examination of the brain by a qualified laboratory designated by the local or state health authority to check for any Negri bodies in that. Okay. This is bites from healthy appearing animals. Bites from stray animals, animals that might have exposed a person to rabies, should be reported immediately to the local authority. Okay. Any stray or unwanted dog, cat or ferret that bites a person may be euthanized immediately and the head submitted for rabies examination. Okay. The call let the particular authority, the local authority take. Rabies post-exposure prophylaxis schedule. So now there is an animal bite and the patient has come to you. So how are you going to proceed? what vaccine are you going to give? How are you going to give the vaccine? So this vaccination depends upon if the patient is immunized or not immunized already. Okay. So if the patient is not previously immunized, then number one, wound cleansing. Cleanse all wounds with soap and water. Irrigate wounds with 9:1 diluted solution of povidone iodine if available. Okay, very important step, because as we already said you, most of the viral load is going to be at the site of bite for entire incubation period, right? So cleansing with running tap water with soap and irrigation with povidone iodine is almost a must. Next is HRIG, immunoglobulins. Administer 20 international units per kg of actual body weight. Okay, if anatomically feasible, infiltrate the maximum amount of HRIG at the wound site itself, and the remaining volume can be given in a different anatomical site, possibly very far from your vaccine. Okay, because your IVIG and vaccine can mutually neutralize each other. For that reason, you need to give the HRIG at a very far anatomical location than the vaccine. Okay, do not give HRIG in the same syringe as vaccine. HRIG may partially suppress the active production of this antibody. So do not give more than the recommended dose as well. Okay, if it's 20 international units by kg, only give that. Okay, so vaccine HDCV or HCEVC 1 ml over the deltoid region, 1 dose on 0, 3, 7 and 14 should be enough. And if they are immunosuppressed, give 1 more dose. What if they are previously immunized? Okay, previously immunized meaning the antibody titer is adequate. So wound cleansing, cleanse all wounds with soap and water, irrigate wounds with 9:1 diluted solution of povidone iodine. And if they already have antibody, need not give a new antibody, right? HRIG is nothing but an antibody, right? Immunoglobulin, it's like an antibody, right? If the patient is already having enough antibodies in their body because of previous immunization, HRIG is not recommended. Okay. So vaccine HDCV or PCEVC 1 ml 1 dose on 0 and 3 alone. So very, very important. If the patient is already vaccinated, only 2 doses on 0 and on day 3. Only 2 doses is required for previously immunized patient who are now exposed. So the general regimen is either a 5 or 4 dose regimen. The 5 dose regimen is 0, 3, 7, 14 and 28 days. How I remember is like in a February month, 0, half week, full week, half month and a full month. 0, 3, 7, 14 and 28. There is a 4 dose schedule where on day 0 they give 2 vaccines. Okay, 2 doses on day 0. Each dose in 2 deltoid or thigh regions. And next dose is on day 7 and next dose is on day 21. This is a 4 dose schedule. Understand, non-intact skin, that's a breach, or the mucous membrane exposure to the infected saliva or the neural tissue from the patients with rabies also should receive post-exposure prophylaxis. Understand, I am not speaking about animal towards the human. I am not speaking about transmission of virus from animal to human. I am speaking about person to person transmission. Okay, you see a patient with possible or suspected rabies and the investigation is ongoing, and from that particular person, there are secretions which has come in contact with you. Your non-intact skin or mucous membrane has been exposed to the patient's infective saliva or a neural tissue, then you need to undergo post-exposure prophylaxis. Okay, this I'm speaking about person to person transmission. So again, in US to be specific, once they see the patient on day 1 of exposure itself, they give HRIG and 4 doses of rabies over a period of 14 days. The idea behind that is, at the earliest, if you give the HRIG, the benefits is going to be almost immediate. Okay, so on day 1, they'll give 1 HRIG and the first dose. Then the remaining 3 doses should be given in the next 14-day period. Okay, if they are immunosuppressed, the 4 doses will turn into 5 doses. That's all, over a period of 28 days. That's all. Remember, the HRIG and the first dose of rabies should be given as soon as possible. But if delayed, you can give preferably within 24 hours. Okay, so if HRIG is not administered during the first rabies vaccine, that HRIG can be given up to 7 days. Okay, so on day 0, you saw a patient. If you have missed any of the vaccines, then you can give that vaccine and HRIG within 1 day, within 24 hours. So you get another patient where vaccine has been initiated, but HRIG is not given. So you can give HRIG up to 7 days from the first vaccine. Okay, why is that 7 days? Because within 7 days, whatever vaccine you have given him will try to produce antibodies. Okay, will ask the body to produce antibodies against that vaccine. So it is understood that the body has started producing antibodies within 7 days of your first vaccine. So giving an HRIG beyond 7 days is not going to be much helpful. Okay, coming to the vaccine per se. Rabies vaccine available in US are human diploid cell vaccine produced in human diploid cells, and purified chick embryo cell vaccine produced in the chick embryo cells. Basically, there are two different types of vaccines available. The active antibody response requires at least 7 to 10 days to develop. Okay, once you give a vaccine, it at least requires 7 to 10 days. So if the patient is not exposed to immunoglobulins, then you can give immunoglobulin within 7 days. Okay, all currently used vaccines are produced in cell cultures. Okay, because they are less toxic than the neural tissue cultures. Nowadays, we don't see any neural tissue cultures at all. Okay, so vaccines do have side effects. The side effects of human diploid cell vaccine are mild erythema, swelling, pain at the injection site in up to 90 to 10% of patients. But understand, are you really worried about this mild erythema, swelling and pain at the injection site? Because this disease is going to be extremely fatal, right? So we can forego all these minimal complications and you can proceed with vaccination. Still, the patient can have systemic reactions like headache, nausea, abdominal pain, muscle aches and dizziness in up to 5 to 40% of recipients. And sometimes severe egg allergy is actually contraindicated to use the purified chick embryo cell culture vaccine. Okay, you need to ask about the egg allergy in patients if at all you are using the purified chick embryo cell culture vaccine. Next complication is going to be the serum sickness like reaction. That's a type 3 hypersensitivity reaction. It occurs in 6% of patients receiving booster doses of human diploid cell vaccine. So this reaction usually occurs in less than 21 days, less than 3 weeks after the booster dose. Okay, and such reactions is not life threatening, and it's reported only with the other vaccine, not with the purified chick embryo cell vaccine. Okay, sometimes the anaphylaxis and neurological symptoms do occur. They are extremely rare. So rabies prophylaxis should not be interrupted because of all these minimal, very small adverse reactions or side effects. Okay, if at all there is an adverse reaction or minimal erythema, use some antipyretic, use some anti-inflammatories and get rid of all these minimal adverse effects and proceed with complete vaccination. Let the antibody titer rise.